Hello, and thank you for joining Antibiotic Stewardship in Prescribing in Equine Practice, featuring Dr. Laura Hardyfeld. My name is Nicole Cast, and I'm the Continuing Education Program Manager for the Minnesota Veterinary Medical Association. The MVMA is pleased to be one of the hosts of the Antibiotic Stewardship in Veterinary Medicine webinar series, along with Minnesota One Health Antibiotic Stewardship Collaborative. We're also working in partnership with the Minnesota Board of Animal Health, the Minnesota Department of Health, and the University of Minnesota's College of Veterinary Medicine. During today's webinar, I will provide technical assistance. If you do have any questions during this session, please type them in the Q&A area. With that said, I would like to turn over the session to our moderator, Dr. Amanda Bedoin, Director of One Health Antibiotic Stewardship with the Minnesota Department of Health.
Thank you, Nicole. Welcome to the Antibiotic Stewardship in Veterinary Medicine webinar series. I am Amanda Bedoin, Director of One Health Antibiotic Stewardship at Minnesota Department of Health, an adjunct assistant professor in the University of Minnesota College of Veterinary Medicine. In my position, I work with professionals in human, animal, and environmental health to improve how we use antibiotics and to lessen their adverse impacts while effectively treating infections. The Minnesota One Health Antibiotic Stewardship Collaborative is made up of folks just like you, professionals interested in leading our state's multidisciplinary approach to stewardship. The collaborative has joined forces with MVMA to bring you a terrific lineup of webinars. The expectation is to be good stewards of antibiotics. This is real and present. This webinar series is intended to provide background on the problem of antibiotic resistance, the solution of stewardship, and to provide actionable information for all sectors of veterinary medicine. This is the last in our 5-part antibiotic stewardship webinar series. Today we are joined by Dr. Laura Hardyfeld, a veterinary large animal internal medicine specialist, doctoral researcher and lecturer in veterinary biochemistry in the Faculty of Veterinary and Agricultural Sciences at the University of Melbourne. Dr. Hardyfeld has tremendous experience in studying antimicrobial use in equine medicine and exploring interventions to improve practice. In collaboration with the Equine Veterinarians of Australia group, she works to develop impactful resources for members of the veterinary equine community. Thank you very much for presenting today, Dr. Hardyfeld.
Thanks for having me, Amanda and Nicole, and I'm really excited to be presenting this presentation. So I'm going to get right into it because I have quite a few slides to get through. So Dr. Srinivasan from the CDC said, the end of antibiotics ? Well, now I say you can change the title to the end of antibiotics period. This reflects that in less than a century, we've gone from a pre-antibiotic era where this is death rates from pneumococcal pneumonia. And you can see before antibiotics were induced, less than 20% of people survived this infection within about a 3-week period. The post-antibiotic era, the antibiotic era introduced profound optimism for survival of infectious diseases. But now are we entering this final phase of this optimism and entering a phase of the post-antibiotic era. So these graphs show susceptibility of pneumococcal infections in Australia, and you can see that resistance to the most common antimicrobials is all increasing, and these graphs go from around 1994 to 2005. But probably the truth lies somewhere in between, like with most controversies. So in all of these resistance rates are only around 20 to 25% of the infections. And so antimicrobials will continue to be critical and effective, generally effective treatments for bacterial infections, but their usefulness will be countered by the ability of bacteria to resist these effects. And also in veterinary medicine, we have this additional challenge of pressures to restrict access to certain drug classes that are of increasing importance to human medicine with the emergence of resistance. And the times are changing. So I think many veterinarians or veterinary organisations have taken this head in the sand approach to this problem, and it's not an approach that we can afford to continue from now on. So we really need to be addressing this issue in a much more positive way. And antimicrobial resistance is becoming a bigger problem for equine vets. So these are just some of the cases that I've seen in the last couple of years. And so this is a multi-drug resistant Pseudomonas that was in this horse, causing a melting corneal ulcer in this horse's eye. And this horse actually went on to lose its eye after having 2 failed surgeries before we got the culture results back to show that that was a multi-drug resistant pathogen, a pan-drug resistant pathogen, in fact. This is septic arthritis in this foal's elbow, and this is one that probably most people are most aware of, and this is MRSA in a incisional infection from a colic surgery. So that's obviously cases that I've seen in Australia. This is some data from the UK, so hospitalised horses and non-hospitalised horses, looking at E. coli and streptococcus, and they looked at resistance in the early 2000s and then the late 2000s, and they found that resistance of E. coli to gentamicin, doxycycline, and tetracycline had all increased in hospitalised horses, and multi-drug resistance in E. coli had increased in non-hospitalised horses. But scarily in the strep zoo isolates from the hospitalised horses, again, we saw pretty remarkable increases. So half of their isolates were resistant to enrofloxacin in the late 2000s. 20% were resistant to trimethoprim sulfur, oxytetracycline and tetracycline had all increased. But I think most scarily for me was in non-hospitalised horses. They still had a remarkable increase in resistance from just 3 out of 55 isolates in non-hospitalised horses were resistant in the early 2000s to 26 out of 62 in the late 2000s. Similarly, they had increases in resistance to doxycycline, oxytetracycline, and multi-drug resistance, showing that resistance is really increasing quite significantly in the UK. In South Africa, 1,500 isolates included in this study. Multi-drug resistance was above 50% in this, and there was an increased trend towards the prevalence of resistance. So again, more convincing evidence out of South Africa that there's a problem. In the US, there's been quite a few studies. I just picked a couple of them. This one is out of UC Davis, 1,000 isolates from foals, and they had increases. They looked at quite a few different bacteria, but they showed an increased reduced susceptibility to gentamicin in Enterobacteriaceae, Actinobacillus, and beta hemolytic strep. They also had increased MIC values for amikacin. They had decreased resistance to ceftiofur in their E. coli isolates, and also Enterococcus and Pseudomonas showed a reducing susceptibility to ceftiofur. Very importantly to me, Enterococcus became more resistant to imipenem and ticarcillin clavulanate over time, and those are a couple of antimicrobials that are really should be very last line in equine medicine. And so, the fact that Enterococcus was becoming more resistant to these antimicrobials over time is quite a telling thing. Out of Kentucky, this study just looked at Rhodococcus equi, and they found that around 3/4 of their farms yielded resistant Rhodococcus equi, and irrefutable evidence of emerging antimicrobial resistance in Rhodococcus equi with alarming prevalence. So, some pretty telling evidence from the US as well. This is Staphylococcus isolates, and I'll just draw your attention to the orange line, but this is resistance to 3 or more classes of antimicrobials, and the dotted line is the trend line. You can see that between 1993 and 2009, this is definitely trending up. This was a statistically significant result, with around 25% of their isolates being multi-drug resistant in the late 2000s. This is a study out of Ireland, and this really just shows the effect of hospitalisation on the acquisition of multi-drug resistance. So in this study, they had 10 horses in hospital on antimicrobials. In the blue is multi-drug resistance, and in the grey is any drug resistance. And so you can see that if horses are in hospital on antimicrobials by day 5, they've got around 70% have multi-drug resistance in their gut. In hospital but not on antibiotics, again, we see this significant increase in the acquisition of multi-drug resistance and any resistance compared to horses that are out in the paddock and not on antibiotics. So if we think about the reasons why we're seeing this emergence of antimicrobial resistance, I think we can really break it down into these 5 categories. So overuse of antibiotics is certainly an issue in the equine sector. And in Australia, placentitis prophylaxis is certainly one that we're tackling here. So trying to reduce this use of antimicrobials in mares that are at risk of placentitis. By the trend is still to treat many of these mares get treated with 5 days of trimethoprim sulfa at the start of each month, and there's quite good evidence now that that is not appropriate and does not prevent them from getting placentitis. The other one, which is certainly a global issue, is the treatment of equine asthma or inflammatory airway disease with antimicrobials. And Scott Weiss has done some nice work that showed that 70% of the horses that presented to the University of Guelph with inflammatory airway disease had been treated with antimicrobials before they presented, and this is a non-infectious disease. So there's probably plenty of other examples of overuse of antimicrobials in equine medicine, but that's just a couple that came to mind. Inappropriate prescribing is also a big issue, and we found in our work that 35 to 70% of antimicrobial prescriptions were inappropriate, depending on the scenario that we looked at. And what do I mean by inappropriate prescribing? This is either choosing the incorrect drug, using an incorrect dose, using the antimicrobial for too long, or using it at a time that means that it isn't going to be effective. So that last one really refers to using antimicrobials for surgery, and we need to have the antimicrobial serum levels at peak levels at the time of the first incision. And so using antimicrobials after surgery for prophylaxis is not effective, and therefore that's an example of inappropriate prescribing. So that's pretty high. Most of these were because of inappropriate doses and inappropriate durations, not choosing the incorrect drugs, but I'm going to talk a little bit more about that later in the presentation. Certainly extensive use of antimicrobials in other species is a risk to horses. Bacteria are transferred between animals and between people and animals in close contact. And I think for this reason, the highest risk to horses is people. And in fact, that multi-drug resistant Pseudomonas that we cultured out of the horse's eye was almost certainly came off the owner's hand. The owner was a nurse in a human hospital, and the Pseudomonas that we found was one that's really restricted to pathogens in people in Australia. So, but I think we need to keep that one in mind. The availability of few new antimicrobials. This is not just a problem for veterinary medicine, but also a problem for human medicine. There's really limited incentive for bringing new antimicrobials to the market compared to drugs like cholesterol medication and anti-obesity medication. But also we have the additional problem in veterinary medicine that any new antimicrobials that are brought to the market are unlikely to be registered for use in animals, so you're likely to be restricted to humans. And so with the drugs we have are likely to be the ones that we're going to, the only ones we're going to have for the foreseeable future. And then there's some regulatory barriers that certainly affect the emergence of antimicrobial resistance. I think off-label use and over-the-counter use are still continue to be problems, even though there's been tightening of restrictions of over-the-counter antimicrobial sales, and I will talk a little bit more about that as well. So why are there deficiencies in antimicrobial use? I think it's a really important question for the veterinary profession. Is it that we have inadequate knowledge of infectious diseases or inadequate knowledge of antimicrobial pharmacology? We looked into this a little bit with our third and fourth year veterinary students in Australia, and we asked them to identify the importance of antimicrobials using the scale that we use in Australia. And you can see that for some of these really important antimicrobials up the top here, they were identified at lower than the correct level for amikacin, enrofloxacin, amoxicillin, clavulanate. And so there does seem to be some lack of knowledge of antimicrobial importance rating, at least in veterinary students in Australia. Unfortunately, this kind of data is not widely available across the globe, and so, but it is something that we probably need to think about. Other reasons why there might be deficiencies: is there a lack of recognition by equine vets for the need for antimicrobial stewardship? I think that's probably a contributing factor. This desire to do something in response to a sick horse, even if the infection is probably not present, that's one that certainly is has been shown to be very important in human medicine. And I think in the work that we've done, it has come up, and it's one that we need to educate our veterinarians about, and provide them with some resources to help in dealing with these situations. Certainly pressure, either real or perceived, from horse owners and trainers is an issue, and that's one that we have identified in the work that we've done. Do we think that owners and trainers are capable of making a diagnosis and deciding on therapy? I think that's something that we really need to ask ourselves when people come in asking for antimicrobials over the counter. Do we think that they know what clinical signs require antimicrobials in their animals, and are they capable of deciding on therapy? And I think the answer to that is no. We go to vet school for a long time to have these skills, and I think that we need to really value the knowledge that we have. And then cultural inertia, or addressing the clinical norms of practice, is a really challenging one for the profession, and something that equine associations, veterinary associations need to be involved in tackling. So why should we do antimicrobial stewardship? I think there is some really good reasons why we should. There is antimicrobial resistance in horses. We've got lots of evidence of multi-resistant staphylococcus, enteric gram-negatives with resistance, enterococci, rhodococcus equi. Is it getting worse? I think yes, but also we're looking more, so that one is not so clear-cut. But changing antimicrobial use is unlikely to affect our patient outcomes. So I think there's really two key messages here. Resistance is unlikely to develop in the absence of antimicrobial therapy. We saw that in the study from Ireland. And the contribution of antimicrobial use in animals to antimicrobial resistance is definitely greater than zero. How much greater than 0 is really hard to quantify. That's really difficult research to do. There's so many contributing factors, but I think it's very safe to say that the contribution is greater than 0. And so we have a responsibility to use antimicrobials responsibly in animals. So this is some research that I did looking at how veterinarians feel their individual prescribing affects antimicrobial resistance in humans. So in black, we've got the overall contribution of the veterinary profession to antimicrobial resistance. So you can see that most people think that there's a moderate contribution, but when we ask them about their individual prescribing, most people think that individual prescribing has a minimal effect, and this is really common. So this research has been done in GPs as well, and the same results have been found. So I think it's important to realise that greater abuse in other areas doesn't justify our injudicious use. And also that this finger-pointing approach that, you know, somebody else is doing it worse, and that, you know, we don't need to change our antimicrobial prescribing is really not helping. So virtually all groups that use antimicrobials sometimes use them improperly, and we all need to change our prescribing practices. I think finally, the lack of proof of harm doesn't justify our injudicious use. So just because we can't prove that it's harmful doesn't mean that you can that you should be using these antimicrobials irresponsibly. So most countries, including the US and Australia, and have these antimicrobial resistance plans and implementation plans. They're all pretty similar. This is the one from Australia, and in implementing effective antimicrobial stewardship practices is present in pretty much all of these plans. So what is antimicrobial stewardship? Well, I really like this definition from the European Society of Clinical Microbiology. It's a coherent set of actions which promote using antimicrobials in ways that ensure sustainable access to effective therapy for all that need them. And I like it because it has the word actions in it, and I think that actions are really important in this space. Antimicrobial stewardship is a real buzz term. It was kind of created here or coined in the early 2000s, and you can see that the number of citations since then is really skyrocketing. So it is a buzz term, and in hospitals it's been very successful at reducing inappropriate prescribing, improving patient outcomes, and reducing the adverse consequences of antimicrobial use. In most situations in hospitals, they apply a whole bunch of different interventions or strategies. So pre-approval of antimicrobials of high importance. So this is where you have to have approval to be able to prescribe these antimicrobials. Prospective audit and feedback. So either infectious disease physicians or pharmacists that are looking at the prescriptions and auditing them before they're filled. Education is a huge one. There's really good guidelines for human medicine, and that has a huge effect. And formulary restriction really goes hand in hand with pre-approval, where drugs just can't be prescribed by certain people without permission. Some of the intensive animal industries in the US have also developed antimicrobial stewardship plans. So these are ones that I found, so the pork industry and the beef industry, and some of this is really being pushed by the commercial sectors as well. So antibiotic-free meat in places like McDonald's and that sort of thing is really pushing these sectors to do better. In companion animals and horses, it's really been quite a slow uptake, but there is a lot more happening in the last few years. So there's a lot of work looking at antimicrobial use and in dogs and cats in the UK. And most of this work has been restricted to the UK, although we've done quite a bit in Australia in the last few years as well. And there has been some antimicrobial stewardship programs, those hospital-style programs being put in place in the US and also in Australia as well. I'll talk more about what they look like in a little while. So I think there's as much risk in doing nothing as doing something. So if we do nothing, antimicrobial resistance will increase. There'll be increased pressure at a regulatory level to restrict veterinary use of antimicrobials, and that has certainly happened in Europe. So in the 1970s in Europe, there was a growth promotant ban on these three antimicrobials. But then since then, these northern countries, the Nordic countries, have really pushed, and in 2006 there was a ban on all growth promotants in Europe. Sweden and Finland and Denmark have gone further, and they've limited the profit from antimicrobial sales in veterinary medicine. So in Sweden and Finland, you can only mark up antimicrobials by 10%. In Sweden and Denmark, there's been a ban on prophylactic antimicrobials in animals. And in Sweden, there's a ban on veterinarians dispensing antimicrobials, and only penicillin can be used unless culture and susceptibility indicates resistance. So really very restrictive prescribing by veterinarians in Sweden. And just recently in France, there was a ban of veterinarians using these critically important antimicrobials unless culture and susceptibility indicates it's the only option. So, you know, these moves are moving out of these Nordic countries into more southern Europe and becoming more widespread. So finally, there'll be more regulation on veterinary prescribing and dispensing, and that's really going to be in Australia. The talk has been about prohibiting off-label use, banning dispensing of antimicrobials by vets, so we'd have to write prescriptions and send people to the pharmacist, and also this ban or restriction on the profit of sales for antimicrobials, and that's really been driven by this, you know, what people see as a conflict of interest, where veterinarians are making money off drug sales, and so they have an interest in selling drugs, and it's hard to, people see that as a conflict of interest when we're trying to get people to prescribe more appropriately. I think the key things that we need to think about as a veterinary profession is that if other groups make changes for us, it's unlikely that these measures will be directed, it's likely that they'll be directed from outside the equine industry and would be likely to be focused on optimal animal care. And while banning antimicrobial use in horses is unpractical and unethical from a welfare perspective, some of our current practice is equally unjustifiable. And so we really need to, not only for the safety of our patients, but also for the safety of our profession, really tackle this issue. The risk of doing something, there's always a risk to doing something. And I think the risk of adopting antimicrobial resistance, certainly from a business perspective, there is going to be a loss of income from antimicrobial sales. Hopefully the research we're doing in Australia will show that that is counteracted by an increase in services, diagnostic testing, revisit consults and that sort of thing. But I think we do need to, as a profession, appreciate that there may well be a loss from sales. And, you know, this risk that if we don't give antimicrobials to something that needs them, we might increase mortality. That has been looked at quite extensively in the human literature. So this is the change in total antimicrobial consumption after an antimicrobial stewardship program. This is a forest plot, so looking at a whole bunch of different studies. And anything that's over to the left of this graph says that antimicrobial consumption has reduced. Anything over to the right says it's increased. So, but overall, we've seen a reduction in antimicrobial consumption with antimicrobial stewardship programs in human medicine. Similarly, changes in restricted antimicrobials, so the important ones, have also reduced. And this is hospital length of stay after antimicrobial stewardship. So we would think that if antimicrobial stewardship was having a negative impact on patient care, that hospital length of stay would increase. But in fact, hospital length of stay has decreased across quite a limited number of studies in this meta-analysis, but still quite good evidence that there was no increased risk of mortality or increased risk of stay. And in fact, no study has identified this in human medicine. So what are the challenges of antimicrobial stewardship? I think people don't know what it is, no vision, no idea of what we want. There's no incentives for doing this. So in human medicine in Australia, it's required for hospital registration to have an antimicrobial stewardship program, but we don't have those same incentives or motivations in veterinary medicine. Certainly inertia or resistance to change is a huge issue and one that we have a PhD student working on specifically. Veterinary producer attitudes or veterinary conflict of interest, I think this is a really important one, especially in equine practice, where having a big trainer or a big stud can be a really significant part of our businesses, and keeping those people on side and keeping them as part of and keeping them as our customers is really important to our business. And so managing that and changing the way we prescribe antibiotics is really challenging, and we need to address that. Use and resistance surveillance data, this is really not available in many sectors. Having antibiotic use and resistance data really allows us to focus on the issues and see changes that can be both motivating to continue and drive the way that we do these programs. Regulations are really lacking, and regulation is a double-edged sword. So in some ways it can really motivate change, but in other ways it can really restrict the way we prescribe and lead to unintended consequences. So I think we're better off tackling this ourselves, and I'm going to say that again later because I think it's really important. We don't have any good evidence for the efficacy of stewardship in veterinary practice, but I think we're at the beginning of this journey, and we really need to develop these the evidence for these programs. So as I said, it's one of the compulsory criteria in Australia for hospital accreditation. The programs must be adequately resourced, and in large hospitals it's driven by a team. In small hospitals they have tele support and nurses drive the program, but it's really well developed in hospitals. In the community, it's less well developed, absolutely, but they have some programs such as delayed prescriptions, Clean Hands Count, so hand washing campaigns, which I'm not going to talk about much today, but it's really important in veterinary medicine as well. Promoting the side effects of antimicrobials, and healthcare communication, which I think is one that we need to focus more on in veterinary medicine as well. So this is just a example of a formulary restriction where some drugs are unrestricted, others are criteria monitored, others are restricted to infectious disease physicians only, and others are restricted to infectious disease physicians but also have criteria. And so, these sorts of programs can be really effective at both promoting the awareness of the importance of some drugs, but also restricting their use to certain situations. And I guess the history of antimicrobial stewardship in the medical sector has been very different to the veterinary sector. So it's really been aimed at improving patient outcomes. It came about because we had Clostridial difficile outbreaks in human hospitals and issues similar to that, where patient outcomes were really affected. And they've been ensuring optimal use of antimicrobials to improve compliance with guidelines and reduce inappropriate antimicrobial prescribing, but also to reduce the costs within hospitals and reduce drug resistance. Whereas in veterinary medicine, it's really been to restrict antimicrobial use and to limit residues in food-producing animals. So quite negative connotations in veterinary antimicrobial stewardship, and really positive connotations in medical antimicrobial stewardship, which I think affects the way these programs are perceived. And I think we need to take these more positive connotations and bring them across to veterinary antimicrobial stewardship to improve the uptake of these programs. So I'm just going to run through quite quickly some steps to implementing antimicrobial stewardship. I think the first one really is to have a policy, but not only a policy, but to have a procedure template of how you're going to implement the policy. So these are a few that this one is quite widely shown. It's the 5 R's. We've also developed one that's freely available on our website, and I'm going to put up the web address for that later on. You know, it's more of a traditional kind of policy framework. And this is one that we worked with a corporate vet clinic in Australia called Green Cross Vets, and to develop a stewardship program for their hospitals. And so it's quite similar to the one that we have on our website, but you know, I think these can be adopted and beautified for your practice as well. The second really important thing, probably equally as important as having a policy, is having leadership. So you need to have leadership within your practice. It needs to be people who are important within the practice, who have power within the practice. They need to be on board with this process. Otherwise, change is really difficult to succeed, to occur. So we need to create cultural and behavioural change. We need to counteract these perceived barriers, and we need to develop practice level policies. The third one is education, and there's been quite limited education in the past around antimicrobial stewardship, but there is an increasing resources in this area. So this is one that we developed, that the vet schools in Australia developed and we contributed to on veterinary antimicrobial stewardship, but I know that there's great resources available on the One Health website, and I'll put up those details later as well, that are probably more appropriate for the US space. So I'd really encourage you to have a look at those resources and to do some CE around antimicrobial stewardship. There's really some quite good evidence for the effectiveness of education. Printed educational materials alone might have a minimal benefit on both professional practice and healthcare outcomes. So Gager and others found that you find a short-term increase but not a long-term benefit. So we might need some ongoing or more face-to-face education to really have effectiveness in this space. This was just a fun little study that was done by the Chief Medical Officer in Australia. So they sent out letters to about prescribing. There was 4 different types. There was an education-only letter, an education with peer comparison, so looking at the general practitioner's prescribing rate compared to others in their region, and that was just written. There was a peer comparison with a graph, so a graphical representation, and then peer comparison with delayed prescribing, which I'm going to talk a little more about later. And you can see that this peer comparison with a graph really had the best effect, but they did find some effect with education only. So the fourth thing we can do is use antimicrobials better. And there's a whole bunch of different ways that we can do this. I'm going to talk through all of these because I think this is the one that we can really implement straight away in practice, in equine practice. So the first one is to make a diagnosis. I think it's really important here to just remember that culture isn't the only diagnostic tool we have. Doing in-house cytology and blood work is really easy. Cytology is really cheap, and it's a really fantastic tool. So, don't forget about doing a smear and just having a look at it down the microscope. BALs, I think, are a great technique for equine asthma or inflammatory airway disease. And it's would be, I think these are really underutilized in those horses that have a snotty nose, that people are often really tempted just to stick them on a course of trimethoprim sulfa or penicillin. But we do need to remember that, culture is indicated when making the wrong antimicrobial choice could be life-threatening. So for septic synovial structures, I think we should be culturing when the infection looks unusual, when it's not something that we typically see, if they don't respond to our first-line antimicrobials, or if they're likely to involve multi-drug resistant pathogens, so those incisional infections. And while we are constantly playing this balancing game of guessing versus testing, I think that testing, especially when we've got some cheap tools available, is something that we should really be discussing with our clients and recommending to our clients. Second one is to follow local antimicrobial guidelines. So antimicrobial guidelines in equine medicine are really challenging. We have this abundant anecdotes versus evidence-based medicine, which really came home to me when I was doing this work looking at developing some guidelines for surgery, antimicrobial prophylaxis for surgery. And these are the guidelines we came up to. And I just want to draw your attention to the level of evidence that we had. So for clean surgeries, we had a medium level of evidence, and for castrations and arthroscopy, we thought the evidence was relatively strong, but for everything else, there was weak evidence. And in fact, in most of these, there was no evidence. So, for colic, there was some, but for most of these categories, we had no evidence for use in equine practice. So, delving into the literature resulted in strikingly little evidence for common procedure and practice, including optimal drugs, doses, and durations. In addition, I just wanted to draw your attention that the labels for some antimicrobials have really questionable dosing regimes, and I apologise for the resolution. These are just a couple of drugs from Australia, but I know that the penicillin issue is one that is a global issue. Canada has just updated their label, but mostly these are labelled 500 kilogram horses or 1,000-pound horses get 20 mils of penicillin once a day. And those dosing regimes are just really out of date these days. So I think the antimicrobial use guidelines are the best knowledge available right now. And as long as the organisation that you get them from is updating them regularly, they really reflect the best current practice. So this is the one that we developed in our group, but Beaver also has one that is a fantastic resource as well. Use the correct dose. So this is some work that we did looking at doses and dosing frequency for penicillin, gentamicin, and trimethoprim sulfa by Australian vets. In green is the appropriate dose, and you can see that nearly 2/3 of vets were using an inappropriate dose of penicillin, and similarly for trimethoprim sulfa. And most people, a significant proportion, about a third, were using penicillin only once a day. So we really need to be aware of what the contemporary dosing regimes are. For penicillin, we should be using 22,000 international units per kilogram or 22 mg per kg twice a day. Gentamicin, 6.6 mg per kg for adults and 8.8 mg per kg for foals once a day, and trimethoprim sulfur 30 mg per kg twice a day. So having graphs like this in your practice or in your car can be really useful in just having a quick resource to look at. So these ones are using the most common concentrations in Australia, but you can make these up in your practice really easily. Also, having these kind of cheat sheets for what the common drugs are most effective for can be really helpful as well, in just reminding yourself when you're making a decision about prescribing. I think we should regularly review the need for therapy. So you may have seen some of this in the news, the new antibiotic mantra, shorter is better. And so this is in humans, but short course treatment versus long course treatment, and outcomes, very similar outcomes for short versus long course treatment. We do have some evidence in equine medicine as well for colic surgery. So 72 hours of perioperative antimicrobial therapy was as effective as 120 in this group, in this study, and similarly for elective arthroscopies. So this looked at no antimicrobial prophylaxis for elective arthroscopies and found that the incidence of sepsis was not different between these two groups. I think another really important thing is to document the dose and indication in your clinical record. This is a legal requirement in Australia, but it's scary how infrequently that this gets actually written in the clinical record. So why antimicrobials were administered, and it really, I think, it makes us think about why we're using the antimicrobials, and also it's really important when research is being done that this information can be found in the clinical record. Ensure your clients understand how to administer the antimicrobials and don't prescribe antimicrobials just in case. So schedule a revisit, use a delayed prescription, but prescribing antimicrobials just in case is really not appropriate in this day and age. And then finally, in choosing antimicrobials with lower importance to human medicine, I'm just going to talk a little briefly about this. So this is the FDA's classifications of antimicrobial importance to human medicine. So the ones in green are important, the ones in orange are highly important, and the ones in red are critically important. And there's some criteria that they use to develop these guidelines, and it's freely available on their website. So I'm not going to go through it today in the essence of time. But these critically important antimicrobials should only be used where culture and susceptibility testing shows that the antibiotic is effective. There's no first or second line antimicrobials that have susceptibility unless these have been used without clinical improvement. And we need to record the use of all of these protected. So just as a reminder, this is predominantly the third generation cephalosporins, the fluoroquinolones and the macrolides, which are used pretty frequently in equine practice. So these are the ones that we should be really protecting in our day-to-day clinical practice and avoiding their use as first-line antimicrobials. So active interventions can really help improve antimicrobial use, and these are some that we've been working with. The MIND-B acronym is one that we use in Australia, but I'm sure that you have your own acronyms. I'm not going to go through them. Audit and feedback does decrease inappropriate prescribing in human medicine. There's some different ways that we've thought about doing this in veterinary practice, so you can have a senior vet audit recent grads or new team members and provide feedback. I think clinic rounds sessions are both educational and provide a forum for discussing appropriate antimicrobial use. And then we've been working with this 5 by 5 auditing method. which requires people to answer up to 5 questions on 5 or more patients per week. And this is what it looks like in human medicine, but we're looking at adapting this to veterinary medicine. So watch this space, and hopefully we'll have a tool that's really easy to use and allows for directed measurement and reporting of antimicrobial prescribing indicators. Also, having some diagnostic testing guidelines can be really helpful. So these are just some ones that we suggest. So anything that doesn't respond to empirical therapy in cases where antimicrobials with a high importance rating or a critically important rated are used empirically, and in any case where infection is life-threatening. So, you know, and on, you can have cytology guidelines as well, and pesticide testing. You know, just having some guidelines for use in your practice. This is example of a delayed prescription, which has been used in human medicine in general practice. So when you don't think that a pet's illness requires antibiotics, but it's kind of to counteract this just in case prescribing. So if your pet hasn't improved in X number of days or things get worse, you can go ahead and pick up the medication. And so in this meta-analysis looking at a few different studies where they looked at delayed prescribing, you can see that overall there was a positive effect of this intervention. And this is something that we've implemented in a trial in Australia, and we hopefully will have some results in the next 6 to 12 months. The final part of a stewardship program is to monitor something. This is the way that antimicrobials have been monitored at a national level, and so, you know, looking at the mg per kg in food-producing animals, it's not very useful in monitoring antimicrobial use or antimicrobial resistance overall. This is the looking at antimicrobial prescribing for different infections or different scenarios in human hospitals, and the inappropriateness of that prescribing. So for surgical prophylaxis was the most common reason that antimicrobials prescribed, also the most inappropriate prescribing in that group. So this is how it happens in human hospitals. Really nice way to look at the data, but very intensive to collect that sort of data and not very useful in veterinary practice, at least at a general practice level. But certainly at a general practice level, we can look at the proportion of critically important antimicrobials over the total antimicrobial use, and we can pull this out of our electronic medical record systems fairly easily. So this is out of some work that we did, looking at cefovecin, a 3rd generation cephalosporin, enrofloxacin and other fluoroquinolones in dogs and cats. But also we can look at resistance. So this is just over time, the number of resistant infections that were identified in a hospital. So this is a really nice way of looking at resistance within a hospital environment as well. I think another thing that's really important, and I'm not touching on today out of interest of time, but is to protect yourselves. And so we know equine vets carry the highest rate of MRSA in the veterinary profession and possibly in the community at large. And so washing your hands, wearing gloves, it's really important that we protect ourselves as well. So some resources. Our website has quite a lot of resources available. We have antimicrobial use guidelines. I would caution you though, these are Australian antimicrobial use guidelines, and they may not be appropriate for your individual scenarios. But we do have antimicrobial stewardship policy and procedure templates, which are probably pretty useful. We have some antimicrobial stewardship education on our website, and we're working with Equine Veterinarians Australia to develop some more equine-specific resources that should also be available relatively soon. So feel free to have a look at our website, and hopefully you'll find some useful information there. I think you have an amazing resource right on your doorstep, the Minnesota One Health Antibiotic Stewardship Collective, and their website has some really fantastic educational and resources as well. So have a look on that website as well. The British Equine Veterinary Association has the Protect Me toolkit, which is really fantastic and well worth a look. So to sum up, what we can do right now: make a diagnosis, follow some guidelines, use the correct dose, regularly review the need for therapy, document the dose and indication in your clinical record, stop using critically important antimicrobials as first line, ensure your clients understand how to administer antimicrobials and don't prescribe antimicrobials just in case. Choose those antimicrobials with lower importance to human medicine as first line antimicrobials. Protect yourself, and I think also I just wanted to say yes to research so we can develop some evidence base for the things that we do. And I think I just wanted to remind everyone that the best outcome may not be as clear as we once thought, and we need to think about both resistance developing in our equine population right now, but also what our profession will look like in the future. And if this is what the drug room of some of your studs looks like, then maybe you need to have a second thought about who's making the best clinical decisions. Is it the stud owner or the stud workers, or is it you? And the future, I think every practice should have an antimicrobial stewardship policy. We've got no new antibiotics coming, so we need to preserve the ones we have. The antimicrobials with high importance rating, or those critically important antimicrobials, may well be restricted. It might be a voluntary restriction, or it might be an imposed restriction. And I think we need to charge more for our services and rely less on drug sales. I'd like to acknowledge all the people who I work with, both at the Asia Pacific Centre for Animal Health at the University of Melbourne and also the National Centre for Antimicrobial Stewardship. And I'd be happy to answer any questions.
A reminder, if you do have any questions, please type them in the Q&A area. We'll give people a second just to type.
Yeah. So Jose just has mentioned that, asked me to share my opinion on the role of antimicrobial doses recommended by pharmaceutical companies. They tend to be in the low range to resistance development, and certainly subtherapeutic use of antimicrobials, particularly over a prolonged period, will lead to a increase in resistance compared to using a therapeutic dose. And so I think being aware of those contemporary drug doses and using an appropriate dose that's likely to reach MIC for common equine pathogens is really important. So.
Great, and I think that there's another question about how do veterinarians find the time and buy-in to adopt an antimicrobial stewardship program?
Yeah, you know, it's a really challenging part of antimicrobial stewardship in veterinary practice, in that it is funded in human medicine, and obviously, you know, most veterinarians work in small businesses, and so that is a challenge. But I think that in terms of maintaining our social license as a profession and also maintaining the efficacy of our drugs, that it will be worth it in the long run. And so, and hopefully the evidence from the trial the stewardship trial that we're running at the moment will show that it doesn't have a financial impact on a business either. So you can maintain a successful business and maintain your profits even though you're selling less antimicrobials or using antimicrobials more appropriately. But certainly it is a big challenge and does require a kind of a leap of faith by small businesses to take on this this additional kind of strategy within their practice.
And along those lines, it's a different maybe communication strategy too with clients. Equine owners in particular, at least here, as opposed to some small animal pet owners, they tend to, as you alluded to earlier, often have their own bottles of antibiotics and make some decisions before even calling the veterinarian at times, sort of a self-sufficient group of folks. And so curious also about how a veterinary clinic or individual practitioner needs to adjust the communication and conversation piece that goes along with changing behaviors of our clients.
Yeah, and it's a really challenging area in human medicine as well. You know, discussing the need for antimicrobial with clients. I think often clients are very receptive until it becomes their animal that's sick, and then, you know, and that's certainly the same in human medicine. As soon as an individual is sick or their animals are sick, then they're keen to use the antimicrobials that they've got or get antimicrobials for that horse. And so you know, it does take quite a bit of strength and effort by veterinarians to have those conversations. And I think, you know, often people get worn down by the end of the day or the end of the week about, you know, having these conversations about how antimicrobials aren't needed for every yearling with a snotty nose or every horse with a cough. And but it is something that we need to work at as veterinarians and educate our clients. And we know from production animal species that veterinarians are seen as a really good source of information, and people trust us, and we need to use that leverage that we have to really educate people to make better decisions.
Excellent, thank you. Yes, we do have a lot in front of us. Well, thank you so much, Dr. Hardyfelt. We appreciate your time. And also, for those of you who are on the call, particularly for those of you who are in Minnesota, we are certainly happy to engage with you on the topic of equine antibiotic stewardship, either directly after this webinar or, you know, in the future. So thank you very much for your attention, everyone. This was the last in our 5-part antibiotic stewardship webinar series for veterinarians. All webinars in the series are archived online, and we will provide attendees with the website link, and will promote the use of the webinars widely for use in staff training and education. So thank you especially to Nicole Cast at MVMA, and thank you to today's speaker, Dr. Laura Hardyfelt.
Thank you, everyone.